Welcome back to the ACS Bulletin Brief, Surgeons' Voices from the Front Lines. With me today is returning Dr. Frank Opelka. Dr. Opelka has been doing incredible work for many years as our medical director of quality and health policy for the American College of Surgeons. Welcome back, Dr. Opelka.
Oh, good morning, and thank you for having me. It's a pleasure to be here.
Well, you do an absolutely phenomenal job in Washington, D.C., and throughout the country, helping all of us help our patients. What I'd like to talk about today are some of the initiatives. Perhaps you could start by outlining globally how those initiatives line up, and then maybe focus on one of them, and we can come back and cover others on other dates.
Well, thank you for your remarks and your kind thoughts. And I think that's a wonderful idea. There's an incredible amount going on inside the Beltway with regard to quality and health policy. And so we try to put these in manageable buckets, if you will. A lot of this is predicated on this concept of value-based healthcare. Everyone talks about it, but what is it? And so when we look at it, we have focused on the quality aspect of it through the American College of Surgeons quality programs. We focused on the production cost. What does it cost to produce a service? Alongside of that is the price transparency. What are the allowable charges that are paid for those services? And ultimately, how do we get to value-based compensation? And the third emerging area that really has to do with this entire development of digital healthcare is what we term knowledge engineering and knowledge management. What's going on with the Googles and Amazons and the Microsofts of the world in healthcare?
Okay, so if we look first at the quality programs and verification, maybe you can walk us through a little bit about what are those programs, number one, and number two, how they're thought of around the Beltway in Washington, D.C., how we've come to make an impact with those programs known for accurate, reproducible verification of quality.
So this is an interesting challenge. From the policy perspective, this all began with the Institute of Medicine report right around 1999, 2000 to err is human. And everyone decided we needed to measure quality and then ultimately pay for it. Well, that meant defining quality in some way. And when we look at the college, we have a long history dating back to the beginning of the college when we ultimately created standards of care. And then went on after years of running standards assessments of hospitals, we created the Joint Commission. But we turned our attention away from the Joint Commission as the primary focus, and we began focusing on verifying care models like trauma and certifying trauma and cancer, and ultimately then things like bariatrics and so forth. And part of the engine or one of the main pillars of all of this activity was the college registries, where we aggregate data, then analyze that data and create risk-adjusted outcomes that inform a delivery system. So when we looked at what the payer community was doing with quality, what we found is that they weren't creating a quality program. They were measuring quality metrics, and they're sporadic, and they weren't coming together to inform a surgeon and a surgical team about how they were doing. They were just being put into a payment program. So when the college looked hard at the payer community, we saw metrics sporadically applied in a payment program, but we could not find a quality program. And we didn't see surgeons gravitating to these metrics to say, I've got to deliver better care and these measures will help me do it. We found surgeons saying, if we use these metrics, we get paid. And for the college, that was the wrong message. That's not a quality program. So our efforts have been first to inform the payer community that quality looks a lot different as a program than it does as a payment system. And we've been working with the major payers like Aetna, Cigna, Blue Cross, and Medicare and Medicaid, trying to display for them what a quality program looks like. And with the help of the Division of Research and Optimal Patient Care, led by Cliff Coe, we probably have one of the top 2 or 3 programs in the world. And that begins with our verification programs. What these verification programs do, let me back up. If you, Dr. Wexner, were leading a medical team and you asked that medical team to build a cancer program or to build a trauma program or to build a cardiac program, whatever it is, you know there are resource needs to do that. You know there's structural elements. You know you've got to have a process. You know you've got to have data to manage the team. The team has to have meetings and so forth and so on. And you do that as a surgical leader all the time. What we do with our verification programs is to study all these successes all across the country in our profession and distill from them what are the primary elements that when a leader asks to build a program, you would lay down as the foundation and recruit the players, the actors to get involved, to own it, and to deliver it. And that's what our verification programs do. They attest to the C-suite of a hospital or the administration who doesn't know how to do this, but they attest that their surgical team has all the right elements, is resourced in the right way, has the data they need to manage and achieve the goals of care in that program. It's not a facility measure, it's a program measure. And so with that approach, you can look at the data and it shows amazing improvement in trauma care, in cancer care, in bariatric care. We have some of the lowest mortality rates and other event rates like readmission, surgical site infection, and so forth in those institutions which take the verification program and actually operationalize it. Don't check a box, don't say I got it right. They actually live it and they breathe it and they do it. So CMS has seen this and they've witnessed it under our exposing them through Dr. Coe and my efforts jointly. For example, we've been talking to them about geriatric verification. It's a fantastic program that puts together the entire geriatric team for surgical care. And an institution that goes through that verification has a higher degree of likelihood of success in delivering optimal care. The same is true with the surgical quality program known as the RED. So it's not just the reliance on a few measures a payer has. It's not just a few scattered thoughts from a registry. It's actually a formal program that is exactly how we think as a surgical team and how we act together and track a patient's journey and look for where the defects are so that we can actually improve those defects. If that were to be used as the foundation for a payment program, just imagine what would happen to surgical care and how people are focused on optimal outcomes. I've gone on, but that's because this is the short story version that we give on Capitol Hill or to CMS all the time. And I suppose you have some questions, so I'll stop there.
Well, it's very helpful, and I've enjoyed listening. I always learn listening to you, and I always have learned listening to you for several decades now. You have unparalleled expertise in this area, and we all owe you and Cliff huge debts of gratitude. But to pick up on something that you said, Capitol Hill listened, they understand what we're doing. Has it translated yet, or do you anticipate it translating into actual payment differences? For example, if somebody is participating in the MBS QIP or the NIST QIP or the NAPRC or COC programs, will that make a difference at some point in time in terms of how they are viewed, and importantly to the practicing surgeon, how they're paid?
So this is the key question. This is where my work comes in. If you look at that first part of building verification and the quality programs, that's what Dr. Coe and his team have done brilliantly. Now, how do we actually implement that? And there are some barriers. First is just the overarching barrier of change. How do we teach those in the payer community or in the government community that this is real and valid and reliable and it's current and so forth? That's the first step. Secondly, the way the law is written, it's written for these metrics, and they're just throwing things into a payment program, not into a quality program. So there's a little bit of undoing of the regulations and the legislation. And so we are working the Hill and working the various committees of importance about what are these necessary changes if we're going to get there. Third is that we can build a payment implementation in the Medicare Innovation Center known as the CMMI. And in fact, Dr. Coe and I have just completed building one for bariatric surgery, which doesn't take all the standards, but takes the key standards in the verification program, adds in patient-reported outcomes and quality metrics, and creates a scoring system that the government can put into payment. So those are the next steps. How do we take a program and turn it into a scoring system in some of its key component parts so that you can take the challenge on, you can move to succeed in this area, and you can enrich and sustain the program. We're in those early phases right now in the Innovation Center, and we hope to move from the Innovation Center into the full Medicare program in the near future.
Thank you. And the other part, and I'm sure we'll dive into deeper depth on that theme we just briefly touched on, but the other theme, which I think we're going to need to explore in greater detail in a subsequent interview, relates to the interface between the data collected in the various verification and quality programs, of which I think there's 22 or 23 in the college, how those data are communicated into an electronic health record and also to payers in a user-friendly, cost-effective manner where the C-suite doesn't have to look at how many extra people they need to input the same data that's already in the record. And perhaps you could just briefly touch on it now, and then we could cover it in greater detail at a subsequent point.
Boy, is that an important concept. So yeah, it's great to have all these wonderful ideas, and we can certainly design a digital implementation, but if it's not scalable, if it's not affordable, it'll never launch. So building these kinds of solutions and overcoming some of the digital barriers that might be presented to the informatics department or to an EHR vendor, we are actually building a parallel construct of how do we optimize digital services and dashboard those in a way where we can automate a lot of the data flows, maybe not all of them, but we can turn the data flows into clinical knowledge that is meaningful. And then we have to work side by side with our surgeons to understand their workflow? How does this not disrupt them? How does it there when they want it and not there when they don't? You know, the concepts of alert fatigue and things like that. So there's an incredible amount. There's a lifetime of work left. We're just at the early embryonic phase of this. Let's get the concept right, and then let's figure out how to optimize its implementation. And the implementation design is probably going to be more complicated because of the various types of surgeons and the various types of practice. It'll be more complicated with human factors than the actual verification and quality measurement.
Well, thank you. Certainly incredible information, and it is the future, but at least the future is started. Thanks to you and Cliff and your entire teams in Washington, D.C. and in Chicago, because at least you've raised awareness, which is very important. And the systems have been created, and now, as you say, the challenge is in implementation and shifting the paradigm away from ticking the boxes to actually doing things and doing them in such a way that's efficient and effective for us and delivers the information desired by the CMS and the payers. I look forward to some future conversations on these really critically important themes, but certainly would like you to offer any additional remarks you like at this point.
Well, I appreciate the opportunity to talk about this and to talk about all the other elements. I hope we have future conversations to talk about the other moving parts, because this quality piece is just one component. Understanding cost and price transparency and value-based compensation, it's very different from the world we live in today. We have lived as physicians, we see our patients on a journey. But when we look at the business model, it's very transactional. It's one moment in time for a lab or for a CT or for an MR or for an office visit or for an operation or a post-op check. We as individuals construct all of that in our head, but it should be laid out for everybody to read so that it's not just my head, it's the nurses, the pharmacists, the social workers, the wound care team. Everyone can see and read the same concepts, and we can then have shared goals. We spend so much time chasing around our individual transactions and trying to become hunter-gatherers of data that it's wearing us down, and there's just too much to aggregate. So we've got to take that burden away, and that's part of the goal of all of this. We've done so much in medical science, and we've improved so much in the knowledge of medical science, it exceeds our capacity. So how do we actually leverage the rest of the workflow sciences? We're very behind the rest of industry. What happens in the airline industry or the travel industry or some of the other major manufacturing industries, they've lived on these systems like this for 30 years, and they've refined them enormously. We've been living on medical science, and now we've got to bring medical science and technology together to really modernize it. So that's what this effort is, tying it to a business model and unleashing the fabulous medical minds in this framework. It's an exciting future. I'm really part of it, and watching it blossom before me has been a super privilege. So I appreciate it.
Well, you're certainly more than a part of it. You're at the center of it and one of the catalysts of it. Thanks again for all you do, and I look forward to our future conversations, which I hope at some point in time will again be in person rather than by computers.
That'd be great. Looking forward to that.